a little fun topic today. This is a very general topic. We're going to dive into a couple things, and hopefully it kind of sparks your interest on some other things. But tell me what this is. Raise your hand if you know what this is. Okay. See, heads are nodding now.
The old football game.
The old football game. Okay, so what do we call that?
I don't remember what it's called, but I remember playing it.
It was funny. Everybody probably, I'm 54, so everyone's like, okay, I know what that is. This is the first edition. It didn't go backwards, so you had to go forward. It's called electronic football.
Such a good name.
Such a great name. We spent hours when I was 8 years old playing this game. It was so high tech. But it's interesting when you see something and when you look at it, that first, if you knew what it was, maybe somebody like, it looks familiar, looks familiar, looks familiar. But the more you see, the more you understand what it is, right? Okay. This is just a little presentation about nonspecific back pain, but back and neck pain refers to discomfort that does not have a specific identifiable cause, such as herniated disc fracture, infection, malignancy. Instead, it encompasses a variety of symptoms that may arise from numerous, often multifactorial sources. Okay, this is just some general characteristics. I can't see, sorry, if I sit over here with you. They're non-radicular, variable, lack of clear etiology, and multifactorial. They're can be very difficult at times, which is hence the word non-specific. Okay, some examples: muscle strain, ligament sprain, myofascial pain syndrome, degenerative disc disease, facet joint pain. This is not an all-encompassing list, but in some parts of the neck, cervical muscle strain, cervical spondylosis, whiplash-associated disorders, myofascial pain. Whiplash-associated disorders, I think we oftentimes think of that just in, I got whiplash in a car accident. If you're in a car accident, I got whiplash. I don't think we think about sports. I know when I was at BYU, one thing that was always intriguing to me was how fast a women's soccer team can hit a soccer ball. Brandy, how hard does a women's soccer player hit a soccer ball in college?
I don't know the specifics, but pretty hard.
Pretty hard. Okay, does anybody want to take a guess? It's over 60 miles an hour, somewhere 80 miles an hour. So if you ever felt one of those balls, they're not really light. It's not a pickleball. Brandy's probably never had a header at certain times, but there's a lot of data on cervical whiplash disorders just in women's soccer that is starting to come out a little bit. But it's not just a car accident, okay? There's a managerial approach to it. There's a conservative approach. There's education, multidisciplinary approach. These are non-specific pain. It sounds it's just not specific. We don't see something that we need to do surgery on, so it's not that big of a deal. It's actually a really big problem because it leads into other things, and that's why a really good team, especially everybody in here, we've talked about it many times. We've had great talks in here. We had a couple weeks ago on pain syndromes and so forth that are very fantastic, and it takes a big group of people to understand these. Okay, so here's an example. Just a 58-year-old female. This is what came in the clinic. Radicular pain down her left thigh. Began a year ago. Worse than back pain worst back pain, typo, already figured it out, dang it. Over the last few years, was aggravating, leaning forward while sitting, legs give out at times. Did some physical therapy, 6 months, no injection. Was referred in the office or with an MRI. Okay, so this came into the office and you'd go through the history, and so, the MRI was provided because the family doctor realized that we probably should get an MRI, and that was done first. So here's the MRI. Dr. Jackson was supposed to be here. He texted me 2 minutes before. Hey, I won't make it. So anyways, John, you want to comment on this since he's not here?
Yeah, I think that the alignment on this is pretty good, and the discs all look tall. The cross section, I'm assuming, is
This is at L45, just to give you a reference.
we've talked about with Brian's talk recently with facet issues. There is a gap in the facet joint. There's a very small synovial cyst on the left side.
So right in here, people can see it.
Very little, if any, spinal stenosis. A couple of anterior discs that show some motor change.
Okay, so this is the report. I think that was pretty dang good. This is what's on there. I'm going to put them on the spot, but Alex saw this patient first, and no injections, no nothing. Let's go ahead and send him out to pain management. You know, doesn't look surgical. Really, there's a cyst in there, but not quite too much narrowing. But sent out for injections. 60% improvement. After the lumbar epidural steroid, she reported symptoms of her right leg. Okay. Follow-up visit with pain management. SI joint injection was prescribed with some minimal improvement. Pretty active woman. Follow-up back to the clinic. Saw Tyler, and he was like, well, that's kind of weird, so let's order some dynamic lumbar x-rays. Were ordered, okay? So this is the x-ray. Oh, the sun is bad, okay? You can kind of see a little listhesis right there. And on the report, as said, this grade 1 anterior listhesis of L4 relative to 5, which do not appear to significantly change between neutral flexion and extension views. So it's there, but now we have a different perspective. All right, heights appear within normal limits, but on the MRI it looked pretty good. But on this one, we see a little bit of instability, just enough to get some movement there. Okay. So what thought processes changes?
Yeah.
Go ahead.
So one thing about this one that's interesting to me is the X-ray just standing gives you a completely different perspective on that spine than the MRI.
Correct.
Because not only is she slipping forward when she stands compared to laying down with an MRI, but the way that her alignment, she's loading her facet joints. Because the back part of her, or the top of the lumbar and into the thoracic, there's an accentuated curve there. And you wouldn't appreciate the mechanics of this unless you did the x-ray.
The interesting part is the pain management. You'll see provocative tests become positive. So SI joint tests were positive. So it tells us a lot of things. Compensation will happen a lot mechanically. And even in the last few months, we have to kind of remember, I say in the last few months because I've lectured a few times and people forget, or I had a couple emergency department physicians in my office and just going over some things, and they forgot that there's nociceptors or nerve endings into the facet joints, into the ligaments. And he's like, I never thought of it, in 20 years of practicing. It changes outcomes, or changes your perspective of how you refer, right? So when you have something like facet disease, that can be very difficult, I think, sometimes, because sometimes it could be the primary, sometimes it can't. But in this one, you can see where it was a big problem. So every time, which made more sense now, when she sat down and kind of moved, it would hurt and give her some relief. Legs would give out sometimes. Suffering from this for over a year. This case ended up going to surgery and a T-lift was performed. So just something that was needed on this person, okay? Here's another case. This is a 50-year-old female. Neck pain started a year ago following an accident, okay? No imaging, but received, everything looks okay. So let's go ahead and start treating, okay? As soon as she was treated with different modalities, she had really bad pain in her neck, okay? They worsened pretty bad, okay? So when you get an image, a lot of times flexion extension x-rays or just x-rays are ordered. And we look at this, there's some dynamic x-rays and not much is going to be seen. You can really dive into some little mechanical stuff, but we dive into here. We can I don't know if everybody focused down on these little movement patterns like this. Nuchal ligament's a lot, dang it, what'd I do? A lot bigger here than here. So there's going to be some movement changes in that area. Remember, anything over 11 degrees, even in Sentinel Spines, which is an arthroplasty and mechanical device company, anything with a 3 millimeter slip or 11 degrees is contraindicated for a disc replacement. So that's how movement is pretty important when we look at these things, okay? But that's an x-ray. Anybody see anything else on it? I'm just throwing it out there, okay? So you get an MRI. What do we see in the MRI?
Go back to the x-ray for a second. When I've gained an appreciation for this over time, I think. There's a couple of maybe mildly degenerated discs in the lower cervical.
Mm-hmm.
And then C3-4, the facet joint translates quite a bit more than the other joints.
Just right here.
On flexion.
Yep.
And so as the disc degenerates, the alignment has to change. And the way it changes is compensation above, so that the facets get loaded in compensation. So,
correct.
What I like about thinking about these cases, because you present these histories and they just sort of seem bland, and we've heard this 100 times, is to not be satisfied with that, but to try to dive into some of the nuances so that you can get more and more specific as to why somebody's having.
Yeah, I think that's super important, right? Like we try to look for the obvious. When we order an MRI, MRIs are made to look at discs. That's what the templates are for, or when you order a cervical MRI, they are designed to look at discs. So the slices are going to attempt to go through disc planes and look at generalities of the cord and compression. Those are things that when you order, that's what they're looking at. The radiologists are trained to look at. And that's why I was wanting Rich to be here. He was telling me this. This is what we're trained on. We're trained to look at discs. That's what stands out. So you can kind of see a little bit, but when you look at an axial view, this is what you see. But does anything jump out at you real quick? It's kind of hard it goes back to the very first slide I showed up. If you see something, maybe you have an idea of that football game, electronic football game, once you kind of look at it, or it takes a team of people to look at it. This one's really interesting, but if you see this view, this is a really bad sprained facet capsule at C23. Does everybody see it? And there's the plane cut through it, but if you're not looking for it, they're hard to see. So we can do our provocative tests, we can do distraction, compression, spurlings, and we're going to get something, but maybe not radicular, but something's weird. Sometimes it takes a team to kind of like, do you see something on it? Don't be afraid to look at it. This is one Tyler and I looked at, and it was something you just don't see very much, but the reason why is because they're not, the MRIs are not trained, or they're not ordered to look at this.
On those ones, the parasagittal MRI for the facet joint is much better than the axial, as you can see there. So when I'm looking for facet joint pathology, you're scrolling over on your parasagittal MRI, which is quite clear on that.
On this one. Yep.
And I think that if you go back to the X-ray, you have a degenerated C2-3 facet, so it's less mobile, and you have less mobile C5, 6, and 6, 7 discs, and then you have a C3-4 facet joint that's hypermobile. And you start to put that pattern together so that when you get into treatment, you're a lot more specific about how you're treating. You might want to do a radiofrequency ablation, for example, to the C2-3 facet joint. But you would want to be looking to strengthen the C3-4 facet, and you would be looking to mobilize the C2-3 and then the lower levels to offset the strain on 3-4. So it just gets a lot more specific in your...
Yeah, I like how you said where you start looking at images, we go back to the X-ray now after you get an MRI and you start putting things together.
Yeah.
The pieces become more clear and you start going, wait a minute. Imaging can be very, I love imaging. I think it's very important when you look at this. We're actually designing a template with Reyes of just looking at ligament pathology that's not been done. And so it'll be fun to see it because it's in a lot of trauma or whiplash disorders. You see those a lot and they're just not looked at. So a different perspective. And this is something this is a paper I was just pulling up about management of non-specific low back pain in primaries. This is systematic overview. Real quick, they did a PubMed search, 1,500 papers came up, which I thought this was interesting. And then they kind of looked at 1,400, narrowed it down to 52 papers. And then they really dove into that and grabbed 10 papers. And this was some of the interesting facts about some of the places. Individuals with acute low back pain without the presence of red flags, the 6 guidelines, recommended strongly against further diagnostic imaging, okay? Because if you're looking for a disc, that might not be the one that you really want to do. So it's interesting, and I'll get to this here, but why do guidelines, this is kind of towards their conclusion at the end, why do guidelines which have all carried out systemic searches as indicated in the methodology nevertheless use different literature for their evidence base? Why guidelines arrive different recommendations based on the same evidence? So in the paper was discussing that all these papers had conflicting stuff against each other. And these are systematic reviews, okay? So on the last one, the conclusion, current evidence-based guidelines published in the Stratum A countries, which was all about social economic status. However, about 50% of these recommendations are weak or very weak. I put that up because I thought it was, when we're looking at non-specific pain in the neck or in the back, we have lots of people that we look at it with different eyes. Surgical, PT, chiro, pain, we all have a really good set of eyes. And every time I spent time with many individuals in here, I learned simple little things that can change the way your eyes can be opened a little bit to what you're seeing, okay? Because when you see something and it appears like you know what it is, a little bit more data gives you a better knowledge, okay? So what do we see here? So we see a picture, okay? Can be different things. Devin, what does it show? What do you think that is? This is not a wrong answer in this. This is just a
Jelly beans.
jelly beans. Thank you. I'll give you. All right. What else? That's okay. Does anybody know what this is? Tiramisu. Thank you. All right. So we got tiramisu in a plate with some jelly beans. Okay. Would you agree with that, Alex? That's jelly beans with tiramisu? Okay.
I agree.
Okay. So now we're going to take one more picture. Now what is it? It's a birthday cake, right? Right? You think? Remember? Because we put a candle there. So it's a birthday cake. All right? We're getting a better, clear picture of what this is. Okay? But if we see this, it didn't show it. That's somebody celebrating their birthday with tiramisu, right? Anyways, so as we think about the stuff that we're looking at on a day-to-day basis in all our tests, I would just point out these, just a couple of cases, there's a lot of non-specific pain. I think one other thing that we see a lot is Bertolotti's. These pseudo joints can be very difficult. Some are very asymptomatic and some aren't. And what do we do with those? We really want to dive into some of these non-specific pains before we just say, let's time for surgery. But the more we look at it, and if it does need surgery, they do well with it, but we have a better understanding of it afterwards. Okay, thanks.